So the next one will be the sideroblastic anemia. So sideroblastic anemia, for understanding this, you need to understand the heme synthesis pathway. So for in heme synthesis, the first thing which is the succinyl-CoA, it starts with succinyl-CoA. So succinyl-CoA is going to be acted upon the enzyme ALA synthase. ALA synthase, along with that, it needs a cofactor which is vitamin B6. The ALA synthase in the presence of vitamin B6 is going to form delta amino levulinic acid, which is delta ALA. So delta ALA is going to be acted upon by further enzymes like ALA dehydrogenase, forming porphobilinogens, and various porphyrins are going to be produced. So final step is going to be the conversion of protoporphyrin, which incorporates iron. Along with that, with the help of this enzyme ferrochelatase, it is going to form the heme protein. So the final step is the heme formation. So this is the heme synthesis usually. So in sideroblastic anemia, there is going to be something which is defective in this heme synthesis. So either the enzymes in the heme synthesis are going to be deficient, or something is going to block these enzymes, or there is going to be deficiency of the vitamin B6. So the first step itself, this is the rate limiting step. Okay, so this is the rate limiting step. So without vitamin B6, this step cannot proceed. So even vitamin B6 deficiency can cause sideroblastic anemia. So isoniazid drugs, which is an ATT. So when you give that, it is going to lead to the deficiency of vitamin B6. So that one, and then alcohol and lead poisoning. So alcohol and lead poisoning, this is directly going to inhibit the enzymes. So especially the ferrochelatase enzyme and ALA synthase enzyme are going to be inhibited by the lead. So lead poisoning is an example of sideroblastic anemia, and both sideroblastic anemia and lead poisoning are examples of microcytic hypochromic anemia. So the pathogenesis involved here will be, so some whatever be the cause, there is going to be decrease in the heme synthesis. So when heme synthesis decrease, heme cannot be incorporated into hemoglobin, so hemoglobin synthesis also decrease. So when hemoglobin is not formed properly, there is going to be excess of free iron there. So it is not getting incorporated into the heme, right? So free iron is going to be there. So this free iron is the one which is going to deposit in the mitochondria. So free iron is going to deposit in the mitochondria, and especially it is going to have a specific arrangement. So mitochondria is going to be present around the nucleus. So it is going to try to deposit in the mitochondria, giving a ring-like appearance. So iron granules are going to be deposited in a ring-like fashion around the mitochondria, and this is going to cover at least more than 1/3 of the nuclear circumference. And you should at least have 5 granules. So at least 5 iron granules should be there, which is covering more than 1/3 of the nuclear circumference in a ring-like fashion, that is in the mitochondria. Okay, so this is the classical description of a ringed sideroblasts. So in sideroblastic anemia also, you see this ringed sideroblasts. So where else did we see this ringed sideroblasts? Yes, in MDS. So myelodysplastic syndrome, in RBC the feature was ringed sideroblasts. In WBC, pseudopelgar-Hutton anomaly. In platelet, it was spawn ball megakaryocytes. So ringed sideroblasts can be seen in sideroblastic anemia. And this is the definition for ringed sideroblasts. So this free iron is going to deposit in the mitochondria, forming this ringed sideroblasts. And apart from that, this free iron is a damaging factor, right? It is going to be a free radical. It's going to cause free radical by Fenton's reaction. It is going to generate free radicals by the Fenton's reaction. Both copper and iron are toxic, right? So free iron and copper, they can involve in Fenton's reaction, producing free radicals. So whatever free radicals are produced, they are going to be toxic to the RBCs and damage them. So furthermore, the RBCs are getting damaged. So the hemoglobin which is present in the RBCs are going to be released. So from the hemoglobin again, iron is going to come. So already there was excess iron which was free. Now again with the RBC damage, excess iron is going to come. So this cycle is going to repeat. So excess of iron is going to be there, leading to a state of iron overload. So this is an exact opposite of iron deficiency anemia. In iron deficiency anemia, iron is deficient. In sideroblastic anemia, there is iron overload. Okay. So what will be the findings? It is going to be the exact opposite of IDA. So serum iron here will be elevated. Serum ferritin, obviously, when the iron is there, storage form is also going to be more. Iron overload, it is going to get stored. Then the serum transferrin saturation, it is going to be more because lots of iron is there. It has already taken up all the iron possible. So saturation also is going to be high, and the total iron binding capacity will be low. It is going to be like enough. So that kind of a thing. So TIBC is going to be low. So this is the exact opposite of IDA, right?